Hi everyone. Thank you so much for joining. So today we have Dr. Nabeel with us here to talk about advancements and controversies in oral and maxillofacial surgery and trauma. Um, I will also be attaching a link to our UKMLA platform called EduSynapse in the chat, and we've also attached a QR code at the end of the presentation, which from which you can join the WhatsApp group. So over to you, Dr. Nabeel. Thank you so much for joining us.
Hi, thank you for inviting me. My name's Nabeel Bhatti. I'm a consultant maxillary surgeon here at Barts Health, and I subspecialise in the NHS anyway in trauma surgery. So I'm going to talk to you about some of the advancements and some of the controversies in my subspecialty, and hopefully give you something to think about. Disclaimer, I asked one of my I wrote this afternoon. I asked one of my SHOs in theatre to help me use AI to make it look nicer. So this is made with some sort of AI tool, but apologies if it's not very good. Open-face trauma involves facial injuries of skin and fat, bones, and teeth-bearing structures, so dentoalveolar structures. And the common causes include road traffic accidents, interpersonal violence or assault, sport injuries, and falls. And increasingly, suicide attempts. We're seeing, especially since COVID, a lot of failed suicide attempts will come our way, with patients sustaining quite nasty facial injuries. And our goals are to restore form and function with a mind for aesthetics and to minimize long-term morbidity. And this includes psychological morbidity from a facial injury. And to that end, we have highly specialized psychologists embedded into our facial trauma unit here at Barts Health. So how has trauma care in MaxFax evolved? So if we think about the bones, which are the building blocks of any face, in the 1940s and 50s, wires and external fixators, which you might have seen on legs, were used in the head and neck to provide rigid fixation, to put the bones back into the right place and allow healing to occur. And as we moved on and technology advanced and surgical technique advanced, we started using titanium mini plates, which allowed for a physiological fixation or using physiological fixation principles. So using mini plates that had some give in them, but were placed along lines of tension and compression, so to allow the healing of bones with less invasive incisions and less downtime for patients. And moving forward onto having CT readily available and to help with diagnostics, again, surgical techniques evolved using minimally invasive incisions and more imaginative plating and screw design. And we don't routinely use, but for difficult cases, we will use digital navigation, which allows on-table use of CT scanning and navigation software to ensure that we're putting the bones in the right place. So there has been a shift from immobilization to very specific, patient-specific reconstructions based on sound surgical principles. So CT has been a game changer, and three-dimensional imaging and virtual surgical planning, or VSP, has, in my career, has changed the way we do things. And I imagine that intraoperative navigation will become more commonplace. And as we embrace AI and predicting how fractures behave, we may see a sea change again in how we certainly risk stratify injuries, and make decisions based on AI algorithms, which might suggest that one kind of fixation will succeed over a different kind of fixation. And certainly in my area of interest, which is high jaw joint fractures or orbital fractures, I'm starting to explore how AI might influence my surgical treatment decisions. Not carrying out the surgery itself, as in other fields in head and neck where robotics has taken off, but risk stratifying and tailoring the surgery that you do according to the injury type. So advancements in surgical fixation, modern trends really have gone towards 3D printed plates and patient-specific implants. And you can see here, this was a revision case that I had to treat, where the break in the mandible was here anteriorly, and previous surgeons had tried to fix this, but had come foul of osteomyelitis of the jaw. This is a dirty injury, and I used a patient-specific titanium plate to fix this along with a bone graft. And we have the option now of using systems like Hairless Martin's Sonic Weld system, which is a biodegradable fixation system. And a lot of patients will, given the choice, would like a fixation system that gradually dissolves and is they're no longer carrying around these bulky titanium plates. But one must, as a surgeon who's going to deploy these technologies, you have to weigh up the predictability and the robustness of titanium over these resorbable systems. And certainly for a case like this, a resorbable system would not be appropriate, simply because it wouldn't be robust enough. And I think that the chances of, so when you have anything that resorbs, from be it a stitch or a pin, there is an inflammatory reaction that takes place. And in a case that's had previous infections, or in a case that needs really robust fixation, you don't want any adverse inflammatory responses to compromise your surgical repair. So for the time being, I'm a firm advocate of titanium over these resorbable systems, but as they advance, I might change my mind. But I haven't really, and the Maxflax world really hasn't embraced resorbable fixation systems, except in the pediatric population and in craniofacial dysostosis, where you have young children, babies who have misshapen skulls, and you might consider resorbable systems in those cases when you have a growing skull. So soft tissue reconstructions. So once you've put the bones in the right place, we have become adept at using free tissue transfer and perforator flaps and microsurgical techniques aid in importing tissue, most commonly from donor sites such as the wrist or the thigh, when you've lost substantial amounts of skin and muscle and fat. And dermal substitutes and scaffolds such as Integra, which is made from shark cartilage, can be used to encourage the body to heal and to grow its own skin. And stem cells and platelet-rich plasma or platelet-rich fibrin is on vogue now, and certainly has become a huge part of my practice. And you can see here I've made a platelet rich plasma plug, which I'll use as a membrane to cover a fracture site. And certainly with bone grafting, my colleagues in implant dentistry use this a lot to increase the uptake of their bone grafts. And I've transferred this over into trauma surgery to, again, when we're missing bony structures, or we want to make the environment as good as we can for healing, the use of platelet rich derived products from the patient themselves is commonplace. Orbital and mid-face trauma, you can see here there's a little orbital plate, and this was an on-table film taken to assess its position. We're now more and more using patient-specific implants. So you come and see me with an orbital fracture, and I send your scans off to the company we use, is a German company called KLS Martin, and I send the scans off to Germany. They plan the implant along with me and send us back a patient-specific prosthesis, which improves. Well, it kind of doesn't make the surgery easier, but it makes the surgery more predictable, and in certain cases, it improves outcomes. And navigation can be used with this, and this is when you use a CT scan live with the patient and use a pointer to establish bony landmarks. When do you repair orbital and mid-face trauma will always be debated amongst the Max fraternity, and I was trained by Professor Holmes, who's an advocate of early repair, and I think I've changed my mind somewhat, and if there are no orbital motility problems, I often now elect to delay repair to see whether the patient suffers from any ophthalmic changes or any subtle asymmetries, which I can address at a later stage. And COVID pandemic meant that access to theatres was somewhat reduced, and we were having to be very case selective on those patients we elected to repair early, and those that we decided to delay. And actually, because of that, I learned certainly that delaying surgery in selected cases is not a bad thing. So in this country, we very much use an open approach to treat orbital trauma. On the continent, some of my colleagues have shown great success with using an endoscopic approach, so going in through the sinus to treat it from below, with balloons, etc., to prop up the orbital floor. It's not something I have a lot of experience with, and would I'd be very interested in seeing how they approach medial wall fractures and combined floor and medial walls before I embark on that. But this tagline here is that it requires precise planning to restore vision and facial symmetry. One of the great craniofacial surgeons, Tessier, described craniofacial surgery as orbitocentric, and I certainly prescribe to that, with the orbit being hugely important in how the rest of the face hangs together. So precision around orbital surgery and maintaining the aesthetic of the eye is of extreme importance. So mandibular trauma is has moved on leaps and bounds, and simply because of the advent of titanium mini plates. Before mini plates, if you had a fractured lower jaw, you would have your teeth wired together for a period of time, usually a month and a half, and the body would be allowed to heal by itself, and that would have a number of consequences. One, emotionally and psychologically for the patient, that's difficult to deal with. Two, nutrition took a backseat. And three, the concept of early mobilization was non-existent. And I certainly treat jaw joint fractures and even body fractures in the mandible with the concept and the philosophy of early mobilization, because I think if you have a damaged joint, to immobilize that joint for any period of time will lead to unwanted sequelae, that be whether that be joint stiffness, a true bony fusion of the joints, or scarring of the muscles that move the joint, which in turn leads to reduced function of that joint. And so you get limited mouth opening, you get arthritic pain, and you get all sorts of, TMJD is an often used word these days to describe facial pain, but you putting patients into prolonged periods of IMF or into maxillary fixation will undoubtedly lead to joint dysfunction. So this is a patient, another revision patient who was treated elsewhere, and when you can see, this is the revision surgery that was carried out on their cheekbones, and if you look at the other side, again, the cheekbone was put into a new position, and if you look at their mandible, you can see that they had a previous fracture here, which I re-broke and repositioned, and on the other side, the condylar fracture was not treated, and she ended up having a total joint replacement. So this combination of kind of relatively old technique, so open surgery to reposition zygomae, and new techniques such as joint replacement was used in parallel to get a good outcome for this revision surgery. So this was actually today, my registrar took a photo of me using some AR goggles to look at bony fractures and look at CT scans, and how this might assist us in both treatment planning and both patient education and trainee education, because we're increasingly becoming subspecialized in the world of trauma. Not all MaxFax trainees get as much exposure to trauma as they might do in a dedicated trauma center like the Royal London, and using augmented reality will help the next generation of surgeons learn techniques that might only be carried out in certain centers. There is an ethical questions to be asked, and this is going to be hugely expensive for a resource-strapped healthcare system, and we're getting registrars and new consultants coming through who've used certain technologies during their training, who've forgotten old techniques, and there's an over-reliance now sometimes with patient-specific implants to forget about slightly older techniques which you must have in your back pocket, because I know from bitter experience that despite all the digital planning and the use of a patient-specific implant, they don't always work, and you must have the ability to fall back on tried and tested techniques to treat your patients. But undoubtedly, digital tools are transforming the way we treat patients and providing patient-specific solutions. And digital tools are also redefining how we educate our future consultants. So post-op care and rehabilitation, enhanced recovery protocols exist in most surgical fields now, and it's no different in OMFS, and the use of cooling masks and patient-specific cooling masks is de rigueur now in my practice. And digital monitoring and telephone follow-up means that the patient doesn't necessarily have to come into clinic for you to follow them up. And we are trialing a virtual physiotherapy clinic for my jaw joint reconstructions here at the Royal London, to see if that can both improve outcomes and improve patient compliance with their physiotherapy. The controversy around this is demonstrating in this resource limited system whether this does improve cost effectiveness, and is this accessible for all patients. You need a smartphone, you need an internet connection, you need the wherewithal to be able to use those technologies, and not all patients can. I have patients in their 80s who I've treated their fractures, their jaw joint fractures, and I'm not sure that they would be able to access a virtual physiotherapy clinic. So those are the kinds of questions that we have to ask ourselves. But rapid recovery and rehabilitation and physiotherapy in the community are goals that will minimize morbidity after OMFS trauma. There are ethical and controversial aspects of OMFS trauma. We're always so I often say that as an OMFS surgeon, I'm trying to restore form and function rather than augment form and function. But nevertheless, it's inevitable that some aspects of the surgery that I do are cosmetic, and when you get hit in the face, your cosmesis is altered, as well as your ability to see or breathe through your nose, or chew your lunch. And we have functional reconstructions, but they have to be aesthetic as well. And without doubt, there are some procedures that are purely aesthetic, and whether they should be funded on a social healthcare system, I don't know. They are at the moment, but we may encounter pushback from commissioning bodies if they're purely aesthetic. There is an inequality to access to technology. I'm very lucky in that I work in a tertiary referral centre with, albeit increasingly reduced resource, but no one stops me from ordering patient-specific implants or using the latest technology at the moment. That may change, but at the moment, like I said, I'm very fortunate to work in an environment which affords me that capability, and affords my patients access to technology. You know, if you went to a DGH, they might not have that access to the technology, and ensuring that is available for all patients is controversial. Data privacy and AI ethics. We must make sure that we conform to all GDPR regulations at all times, and that means that certainly things that or programs or software that can be used in the private sector cannot be used in the NHS, and we must protect our patients' privacy at all times, and that's very important. And there is a training gap in new technologies, and Surgeon X may well have experience of a certain technique, and it's disseminating that that training, that knowledge amongst the wider surgical community, which is which is the responsibility of us all, really. This is an example of a surgical plan that I could not have done without use of digital planning and 3D printing. This is a woman from Kuwait, actually, who I treated in the private sector, who had a subtotal orbital reconstruction, not following trauma, but following malignancy. And 5-10 years ago, this would have been impossible to treat, and is only possible now with the use of patient-specific techniques. You can see this subtotal orbital reconstruction was made using 2 titanium plates that interlocked with one another. So where are we going in the future? I didn't have a picture for this, so I relied on AI to come up with one. We have to embrace AI. It's here to stay, and I suppose your generation will be the ones that take it forward. And I look forward to working with younger trainees and learning from them about how AI might influence the rest of my surgical career. Nanomaterials of bone healing are on their way, and I'm often approached by people on LinkedIn with ideas and products to use to stick bone together and to grow bone in places where you have bony destruction. Gene and cell therapies are a reality now, and although they don't really play a huge role in my practice, it will be something that I will watch with interest. And this is interesting. Integrated trauma systems for holistic care. I think that's something we do really well at the Royal London, where we have a well-established trauma pathway for patients with both head and neck and general trauma. And we have psychologists, we have physiotherapists, we have occupational therapists that allow me as a head and neck trauma surgeon to collaborate with to ensure that patients do get joined up care and are looked after not from their initial insult, but looked after well into their rehabilitation phase. So to summarize, head and neck trauma has evolved through digital and regenerative advances, and we're now using new technologies for improved patient outcomes. Controversies remain, challenges remain around technology, how we integrate that into a social healthcare system, cost effectiveness, and the need for specialized training and advanced procedures. And the future of OMFS trauma is characterized by personalized treatment, data-driven decision-making, and minimally invasive surgical techniques. And this is a picture of a patient who was looking the wrong way. They were here, they were European, and so they were used to patients driving on the other side of the road, and they were looking the wrong way as they crossed the road and were hit by a bus, and had true pan-facial trauma. So they broke their eye sockets, their mid-face, and their mandible, and required extensive reconstruction, not only of the bones but also of the soft tissues as they entered the rehabilitation phase of their trauma journey. So that's all I've got. And I've been asked by Synapse to show you these QR codes. One is for a medical students group, and the other one, I'm not sure what the other one's for, but I'll hand you back to your hosts, and I will happily answer any questions.